withdrawals of alcohol are one of the withdrawals that can actually kill you. So that's something to take of note, or to, pardon me, take notice of, rather. So in the presence of Wernicke's, you want to, the main line here is going to be the use of the banana bag. So everybody's heard of it. And everybody who has been in the military for more than 2 days knows that you're going to, at some point, have a really bad hangover, and you're always going to ask your medic for, an IV bag. So just think of that. At least that's how I associate it. So then moving into the actual pharmacological treatments, thank you to Mr. Reynolds for some of his excellent mnemonics and stuff here. So there's a number of drugs that we can use in order to help actually treat this. I'll get to his mnemonics in just a minute. So going through, we want to start with benzos. Going in order, similar ones as we covered yesterday. Lorazepam is going to be the best one for the liver. Diazepam is going to be your worst one for the liver. And then chlordiazepoxide? Yeah, that one. That's like your medium risk one in terms of damage to the liver. Again, all these metabolites in the liver, long-term alcohol abuse, leads to liver damage. So consider that. So lorazepam and chlordiazepoxide are so this is not in order of first line to worst line, if you will. It's facility or institution centric as opposed to what you're going to use. But generally, lorazepam and chlordiazepoxide are going to be the ones that are utilized more frequently as opposed to diazepam. Your other drugs going down the list, you can use phenobarbital as an adjunct if your other treatments are not working, but check your local guidelines. And then as far as actual pharmacotherapy for cessation, moving forward, I'll get to that in a minute. And then so actual cessation,
Hold on.
Yes ma'am.
Okay, so just so everybody's following the order, because we had the benzos here, went to the chart and specifically talked about them like that for the use of it, right? Because on here it just says benzos are your first line that we're using to try to stop the seizure, okay? So depending on where you are, the institution may change or the provider may change what they want to do. So we had patients who were going through withdrawal, or we were trying to prevent them from going through withdrawal. So like I told you guys, you can order beer. We have beer in the pharmacy. So you give them beer to try to prevent the withdrawal, and then we start them on this medication, and we try to taper them. And this will all be based off of the single protocol. So it depends on what you use. I've used both of these meds, the lorazepam and the Librium. So it just depends on what that provider chooses to do. So when he was saying this isn't in any order, that's what we're saying. Like this, the order of this doesn't matter. It just depends on what that provider or that institution chooses to do. And then on this side, this is just telling you, hey, like I can play with my dosing, essentially on how I want to give it to my patient. If they're experiencing a lot of withdrawals, your taper and how you're going to give the meds are going to be a little bit more aggressive if they drink a lot versus if it was somebody who drank very little. And when you do your C-Well protocol, you'll also see where sometimes you may not even have to give them these meds because the likelihood of them having a seizure or going through withdrawal is very minimal. So we will take this score, we will do the protocol every single day. So it's essentially a survey. And every single day, we go back to make sure that their symptoms are still consistent with us either treating them or not treating them. So this is just saying, like, I want you to know benzos and phenobarb, and then looking at this slide, these are the benzos that we're using, and pay attention to your comments to say, and what patient would I potentially use which benzo, okay? Because remember, we're talking about alcohol about patients who are alcoholics. Are their livers good or bad? They're usually bad, right? So sometimes that's why you'll see where we're using lorazepam over using our lithium instead. So like just on the exam, if you have a question like this, you're looking at these comments to say, which one would I pick for this patient? Not to say that you can't use it, it's just saying it's more monitoring if you use that Librium in your patient who has liver disease, okay? And not every alcoholic has liver disease. Okay, sorry. So are you on this one now?
Yes, ma'am. Okay, so moving on to the actual pharmacotherapy for cessation. Rolling through, starting with acamprosate. So this is a glutamate antagonist. So glutamate is your excitatory neurotransmitter. This one antagonizes that action. It looks and smells like GABA, if you will. It is used for the maintenance and abstinence from alcohol. It is excreted by the kidneys, so as the slide says, caution with renal insufficiency, and then your contraindication would be if they have a decreased creatinine clearance. Disulfiram is up next, so that inhibits your alcohol metabolism and makes you feel pretty shitty. If everybody remembers, I'm sure everybody does at this point, the metronidazole, it helps to or can induce a disulfiram-like reaction if you drink while you're taking that. So you can associate those two things. This is the actual thing as opposed to just a side effect. And then it has drug interaction with metronidazole and then psychosis-related drugs. Naltrexone is a...
Hold on.
Yes.
So on this one, just make sure that you're understanding exactly what the reaction is, right? Because some people will just say, oh, I have disulfiram and that's it, and they're not thinking about the reaction. So your mechanism is essentially inhibiting your ALDH, okay? If I don't have that, then I can't break down the alcohol, right? So it's just accumulating, right? So think about like you thinking, oh, if you drink too much, especially if you drink a lot quickly, and this is something that you're doing, you're gonna vomit. Is essentially the reaction that a lot of your patients end up having. They also will experience just think of it as being kind of activating. So the flushing, the throbbing headache, nausea, vomiting, sweating. Some patients who have AUD will prescribe this. They will take their medication how they're supposed to, but the cravings to have alcohol will be a lot stronger than their dislike for vomiting. So you will still have some people who will take their medication how they're supposed to, and they will have a craving for alcohol. They know what's going to happen, and they will still drink the alcohol. So these meds are only as good as the will of your patient, so to speak. And sometimes you're still going to have to refer them for additional help because our medications aren't going to be the only thing that can help them through, like the addiction portion of it. Okay? So that's why you see does not reduce cravings, high relapse rate. Okay? And they will take it, they'll take their meds, but they're going to also drink, and they're going to just vomit and continue to take their meds for their and then this, when you see DOT, we talked about DOT before with what meds, TV, right? So this is another thing where you're saying like, hey, I would have to directly observe this patient taking the medication. The burden of trying to do this and the efficacy of this whenever we talk about placebo was not great. So that's why a lot of times you don't see, we don't dispense this very often from the pharmacy. Like I don't see this used often. So just when you're thinking about this, just make sure that you're understanding that it's more than medication. With any of these meds that we put our patients on, it's more than medication. It's a lot of work. It's a lot of counseling. It's going to be hard on your patient. So also mentally just checking in on them to see how they're doing is going to be important as well. You're going to have people who are helping you with this. You may end up just with a person who's on one of these meds, so you need to recognize what they are. Did you do, you did this already. Adverse effects, contraindications. When you go to the next slide, let everybody know so that we know which side you're on so that everybody can follow.
Okay, pick it up with naltrexone. So it's a naloxone derivative, meaning so naloxone is an opioid receptor antagonist. So this is effectively the same thing. So it's, as the slide says, it's preventing the euphoric effects and then decreases the cravings. So it's considered more effective than acamprosate, and then it can be given PO or IM. So the PO IM is administered monthly, bottle bullet, then your once daily Q other day. So what? So is that every other day then, or every 3 days, ma'am? Is that like extended release?
So which one, if you had to think between using your oral or your IM, do you think would be better for your patients who have any type of alcohol abuse?
From the PO IM.
IM, right? Because now I don't have to give this to them every single day. I don't have to worry about if they're taking the medication. And then this is the other thing. I have several different options. So the every other day, every 3-day regimen kind of gets a little bit confusing. So if you are writing for one of these, again, make sure that you have them on the schedule. Write the actual days that they're going to take that medication so that they don't forget which days they're taking it. Okay? And then they lose that effectiveness. And then this with the obesity, with your bupropion, it is an option for us to use, bless you. But now with obesity, and we'll see at the end of this lecture, we like to use other medications that are a lot more effective and they're a lot quicker with them getting the weight off. So just understand that this is like in your back pocket if somebody did want to use this and they wanted to stay with oral options and not injections for weight loss.
Okay, so the next slide, effects, and block the effects of opiates. This blocks the receptors, so if your patients are on any kind of long-term painkillers, so that it's going to interact with that, so that can take consideration. Not the headache, dizziness, decreased appetite, and then can be hepatotoxic, so pay attention to your DSTs and ALTs. And then your contraindications are, again, because it can make it not work, and then liver clearance failure.
So this is a very important slide because you're going to have patients who are on pain meds. They are on pain meds, and we just said that I am an antagonist at an opioid receptor. My pain meds work on opioid receptors. So if I'm blocking that receptor, now I'm giving them an opioid, they're not going to have pain. I will also potentially cause withdrawal depending on the dose that they're on, right? Because now you stop that effect that I was typically getting, and I'm not getting any pain relief either, okay? So if you see a patient that's on naltrexone and you're prescribing a pain med, you need to make sure that you're trying to figure out, okay, how can I give this, or can I get them off of the opioid, taper them off of the opioid, and then put them on the naltrexone? Or can I give them a different med that's not an opioid and give them the naltrexone? Or do I have another option altogether besides using naltrexone? Okay, so that's why we're going through these different ones. So if you have somebody who is on a pain med, this is not a good choice for them. If it is an opioid. If I were giving them Tylenol or ibuprofen, that's not hitting an opioid receptor. So this is specifically talking about opioids. So if you had a question, because we haven't talked about opioids yet, I would tell you that it is an opioid. Then your job is to know naltrexone blocks that because it's an antagonist at the opioid receptor. Antagonist at my opioid receptor. Okay?
And then the last ancillary drugs, so see a couple of these again, topiramate and gabapentin.
Take it out of your pocket and see if it looks, or where is it sitting on you?
So the last couple of ancillaries again, so topiramate and gabapentin, we saw last block. So topiramate, it has been shown to reduce consumption in trials, but it's not FDA approved yet. And it apparently has similar efficacy to naltrexone. gabapentin, may help reduce symptoms of alcohol withdrawal. Option if first line, if your first lines are contraindicated or ineffective, or if you're using it in conjunction with in a patient that has neuropathic pain, and then baclofen, there's good data, may help suppress alcohol-stimulated doses. And then again, thank you, Mr. Reynolds, for the mnemonics. For these ones of these, we have the top alcoholics never die with gambling. So pyramate, mecambazole, naltrexone, disulfiram, and then gabapentin. Top alcoholics never die with gambling.
Okay, so your check on learning, 32-year-old, wants treatment for alcohol dependent, 15 drinks a week for the past year. What would be the best thing that we have to help these patients? Right? So why are naltrexone? And then what's the key word that you're talking to? Cravings, right? So pay attention to those little things when we're talking about the drugs and the mechanism, because we have different targets with each medication. Okay? So your big thing here, when we were talking about our acamprosate, this was helping with the withdrawal symptoms and trying to help with abstinence, but not necessarily like a lot of those cravings that your patient was feeling. Your disulfiram, same thing. That one was a deterrent, right? So it's going to give them those unpleasant feelings, but you still have them drinking. And then your gabapentin, again, that was helping more so with some of those withdrawal symptoms that your patient would be experiencing. So make sure that you're looking at them, because yes, they're all in the same section, but we have different little things that each of them can do depending on what your patient needs at that time.
Ready? There's a little primer for everybody.
Is it you in jail?
No, maybe rehab.
Did you hurt yourself?
How did you hurt myself?
Because Coach Blue said after his back surgery, he has to go to rehab.
Oh, okay. Yeah, I hurt myself. I hurt my nose.
Skinny Powers, he's bound it down if you've never seen that. Great show. Check it out. All right, we're doing stimulants the next 12 slides or so. So, as a primer, these first ones we're going to talk about are all amphetamine based. So they're going to be strictly class 2 drugs. All right, and then their MOA is going to be they're going to promote the release. They're going to either promote the release of catecholamines, mainly dopamine and norepi, from their storage sites, or they're going to have some effect on decreasing the reuptake of that dopamine or norepi back into the cell. Clinical uses you can see there: got ADHD, narcolepsy, obesity. Fun fact: when Germany was like a big proponent of this back in World War II. They gave all their soldiers like amphetamine pills, basically. And that's how they did the Blitzkrieg, basically in 2 or 3 days across France and Russia, was giving all their soldiers amphetamine and basically running across the countryside.
And real quick on the obesity portion of this, be careful with patients who have like body dysmorphia, because you can see weight loss with this and they abuse them. So yes, we use it for obesity to help with that, but this is not something that you'll see prescribed that much just for obesity anymore, because again, we have newer drugs that are a lot better. But this is like a side effect that we use as a benefit, but don't let that be the primary reason as to why you would prescribe an amphetamine. Okay? Like typically, we're using it for ADHD and narcolepsy. Obesity is there, but like trying to put that as like a last line type of option as to why you would prescribe this. Okay?
Is that FDA approved or is that off-label strictly?
So I'll have to look, because I don't remember, because most of the time, I have never seen it as the primary indication for why you're using any of these. But we have people who would come in because they lost so much weight, and they would just seek the drug, not because they needed to focus or anything else, but like they loved how their body looked, and they loved the weight loss. So that's why I'm saying we have so many other things now that are not addictive to prescribe for weight loss. So don't prescribe it for that. And I'll look at that right now and be able to check.
Backing up real quick, mechanism of action, to remember that, just remember NDRI, noradrenaline/dopamine reuptake inhibitors. That's your MOA for these next few drugs. So yeah, these are the next slide. The three things they mainly do: decrease motor activity, increase coordination, and then improve your ability to get stuff done, right? So we can all use a little bit of that right now. On the drugs themselves, on the amphetamine drugs and derivatives, they kind of do both. They kind of make the drug last longer in the synapse, and then they also increase the release of the drug of noradrenaline and dopamine. The methylphenidate, that kind of does the second part. That mainly does the second part. It decreases the uptake so that the effects of the drug stay longer in the synapse, and you get the effects from it that way. So, two ways of doing it right there. And we got the list of non-stimulants, which we'll go over at some point, I'm assuming. And then next slide.
And it's off-label, but like I was telling you, now they're saying don't prescribe them for weight loss, which is the same thing I was saying, because we have other drugs that are better. Okay. So not on-label things, just the added benefit that we saw from our event.
So, we're just gonna go over all the drug names. Can you hear me now? Okay, so we're just gonna go over all the drugs. So for the amphetamines and derivatives, the dextroamphetamines and amphetamines, we have our Adderalls and MyDays. So the mnemonic we came up with for this one is since it's mixed salts, if you hit the smelling salts, you're gonna say damn. As Jenny can attest to. Okay? And then we got the dextroamphetamine. So those all have X in their name, except for the Procentro. So that's just exclusion on that one. The lisdexamfetamine, just remember that at least that has a van. And we have the immediate release, next slide. Immediate release.
Hold on, sorry. So this is telling you, the way this is written is kind of confusing than how we do all of our other brand names. So these are all of your generics, and then these are all of your brands that you have. I will only list the first brand name that you see on the slide. But this is just telling you, like, these are all of the different ways that they have branded this generic. So dextroamphetamine and amphetamine, so the mix, these are the names that you will see. Dextroamphetamine by itself, these are the different brand names that you can see in your list. Dextroamphetamine by name is usually the only one that we'll see for that, okay? So this one is a little bit different than how we typically see. So these are your generics, and then these are all brand names.
Okay, so go up. Same rule. For the immediate release methylphenidate, just remember that Rita also does pen. Then you have your extended release methylphenidate. We got Rita again. Yeah, we'll just have to remember something about Rita being extended. And then the immediate release, just focus on, so it's focal length, you're going to focus on the immediate. And for the extended release, dexmethylphenidate at the end, you'll have extra focus on extended release.
So, only other thing from this, look at the different why do you think this is important? When we talk about, oh, I have a chewable tablet, who would that target? Children who can't swallow pills, right? Who have the need for some of our amphetamines, non-representative. When you look at the solution as well, same thing. Anytime you see extended release, you'll see LA, you'll see CR, you'll see XR, you'll see something like that on the end of it. When we look at this orals, this was just a different thing that they branded to essentially say, hey, I'm going to make a coating that's on this tablet to where it releases over a longer period of time. So this is just technology that they use to make it an extended release. And then you see also that you have a patch, which can be convenient for some people if they don't want to take anything orally. But if somebody is very active, they sweat a lot, very hairy, this is not a great option for them because then you have to make sure that the patch stays on them. They're going to continue to come back to your office and say, oh, I lost my patch. And they could be giving it away or doing other things with it. So that's the big thing that I want you to notice, that there are several different ways that we can give these medications to our patients. Yes? Hold on, sorry, I have a question.
What is the CD stand for? Is that
This one is just like, it's like a controlled delay type of release. So anything that you see after a brand name for the most part, if you see any of those things that are at the end, that's telling you that it's probably a longer releasing acting medication depending on what type of system they created for that. Yes?
If you go to this last slide, ma'am.
This one?
Yes. So for this dexamphetamine,
Yes.
is that technically a prodrug or because
You could, it also has activity, right? And you know how some of our drugs, we said you can have inactive metabolites or active metabolites? So, in a way, yes, it could be considered a prodrug, yes. We have several drugs that are broken down from their main component, which can have activity, to a metabolite that also has activity. And this one is another one that has activity. So yes, you can classify it that way, yes. You're here, right?
Okay, so taking legal meds obviously comes with a lot of adverse reactions. The effects on the alpha beta receptors in the sympathetic nervous system is going to respond more to that fight or flight side effects. For the physical CNS stuff, you're going to have increase of tremors, seizures, insomnia. It's going to come with the standard GI issues of nausea, vomiting, diarrhea. But you're going to see a decrease in your growth rate for your peds and appetite, so that's something to keep in mind with the anorexic or child patients. Mentally, you're going to see possible panic and confusion in patients from it, and it can create a physical and emotional dependence, so that's something to keep in mind. For contraindications, no one with any pre-existing cardiovascular issues or hypertension, thyroidism, or glaucoma, once again kind of going back to that alpha and beta receptors and fight or flight, and you'll need to monitor their heart rate, blood pressure, weight, and height, especially in pediatrics because of that growth rate inhibition.
So when you prescribe these, it's gonna be hard because you're gonna have parents who are gonna love these meds and how it makes their kids behave. But you have to remind them of these things, right? That increased growth rate, that decreased appetite, and they think that the growth is decreased because the appetite is decreased, right? So I don't have enough nutrients that I need, so they think that those two things are related. So when you look at this, a lot of times what we try to do is drug holidays. So over the summer, we may say, hey, don't give your kid any meds unless they're like in summer school or something. Try to let them have a holiday or a break from the drug. And that's how we prescribe a lot of these stimulants, where we'll say, let's take them off of it for that time to let them just, be free. They don't need to focus on anything if they're not in school. But some of your parents will refuse to do so. And it's just you trying to educate them. You have to sell why you're wanting to do that, right? Why do you want my kid unmedicated? And I'm going to be stuck at home with this kid all day, like bouncing off of the walls kind of thing. So conversation, education, these are the big reasons why we try to do those drug holidays, is because of that growth rate being decreased with the smaller appetite or less of an appetite.
Alright,
talk about the non-stimulant for ADHD. So stimulants are preferred over non-stimulant because of the rapid onset and has a safety and efficacy long track record. So you will use non-stimulant if the patient, if you see in patient that there's a potential for abuse or patient preference, if they're not comfortable using a stimulant. Also, if they have underlying conditions like cardiac disease, glaucoma, or loss of appetite. Non-stimulants are usually combined with stimulant to kind of help with the improvement, with the partial response or reduce the stimulant dose and avoid side effects. Non-stimulants are slow in action, so you'll probably see the maximum efficacy in several weeks in patient. All right, slide 64. So first non-stimulant drug called tamoxifen. Sorry, I butchered that. Strattera. It's a non-stimulant drug approved for ADHD. It helps block the uptake of norepinephrine, and it's a monotherapy for treatment of ADHD in patient younger than patient 6 years old or older. Let's see. It's not good as a stimulant though, but it's a first line of drug agent. Adverse reaction, they're going to have hypertension, palpitation, weight loss. There might be a QTC prolongation, and then their aggressive behavior may worsen.
So when we talk about this, we'll talk next semester about like opioid sparing drugs, which are drugs that would help you decrease the dose of an opioid, right? Which could be addictive. This is kind of the same thing when you talk about some of the non-stimulants. The big driver to use these are going to be those parents who say, I don't want my kid on the stimulant right now. Let me try something else. I don't want them on a controlled medication, right? So you will see us sometimes starting this, or we will start this with a stimulant to keep that stimulant dose at a minimum. So then they would use these together to decrease the dose of the stimulant. So that's the big idea behind a lot of these. We try to start here and then escalate up.
So we're moving on to bupropion, Wellbutrin. A fun fact is that this is in 2023. This is the the most prescribed medication. Well, here, give me a second. It was the 17th most commonly prescribed medication in the U.S. What it does is that it treats major depressive disorder or seasonal affective disorder, well known as SAD. I put major depressive disorder as super SAD, so you can use this to treat that. Mechanism of actions is a mixed catecholamine effects. It's a weak inhibitor of norepinephrine and dopamine reuptake. It's effective, but it takes several weeks for it to kick in that effect. The adverse effect of it is that you can get that tachycardia, sweating, and tremors, weight loss, and nausea, vomiting, constipation. Contraindication is that don't give it if they have like anorexic, so if you're skinny, super skinny, do not give it to them. Alcoholism, if they drink alcohol, don't give it to them. Next drugs, clonidine, extra release. I think we remember this drug from our first lecture slide. We talked about it briefly. The exact mechanism of action is unknown for ADHD. They believe it acts on alpha-2 agonist, and it regulates prefrontal cortex activity. Their half-life is about 12 hours. Their clinical use is for children whose intolerance of stimulant, especially for those with tics. I would just highlight that just because it's This drug gonna be a little bit similar to the next drug that we'll be talking about. And clinical use also is for impulsive behavior or Tourette syndrome. Adverse reaction is long QT, and sedation may worsen the depression as well.
So a good way to remember this, just like she was saying, you can use these for tics. If you think about people who have Tourette's, a lot of them will have certain tics that they have, and so you try to use this medication to see if you can decrease the tics. They can be verbal tics, they can be movement tics, any type of tics that you see, like this is what it's talking about. So keep this drug in mind because you will have some people who come in and they have a tic and you're trying to see if you can help them with decreasing the frequency of them having the tic. It probably won't make it completely go away.
Okay, right. Next drug, guanfacine. So probably not gonna remember the name guanfacine, but intuitive. I think we got something there. So intuitive, right?
Mechanism of action there is essential. Oh, yeah.
Central alpha-2 adrenergic agonist in the prefrontal cortex. The main takeaways here are it's going to be indicated for children with a tic disorder and Tourette's. The way I remember this would be using the word intuitive, so I'll just think intuitive. Right there in the middle of it, it's got 2, so I think of 2 key takeaways, right? Alpha-2, and then 2 T's, tic and Tourette's. Next slide. 4, adverse effects, hypotension, bradycardia, and a long QTC. So extended release, we think long or extended QT interval, and since it's an alpha-2 adrenergic agonist, it's going to inhibit OREPI, so it's going to drive down blood pressure and heart rate. So, next slide.
Yeah.
Sorry, so when I look into these 2 drugs, I'm trying to like decipher when to prescribe which medication. What is the best when they're both treating tics and Tourette's?
So the efficacy of them may vary in the patient. If I were asking something like, if I were asking a question about something like this on the exam, I wouldn't give you both of those and expect for you to know because then you would be trying to just pick one based off of what you have seen in practice that works better for you. It's kind of how some people prescribe. So that's why I said we tell you guys all of this stuff, and then when you get out and you actually start practicing, you're going to be like, these are my go-to things, and then if these don't work, what do I go to next? So in this situation, there are several drugs that you can use for a condition, like, right? So I can have one condition, and I can have 10 drugs that treat it. Once you get out of your first line of like, and there could be several first lines, there could be one first line. Understand that once you get out of that first line, then you're just kind of going down the list and saying, I hope that something works, right? So in this situation, you would be just picking to see if it improves something. A lot of times, the providers will add these on to the stimulants to see if they work. So how you see here with this one, it's saying like, there's limited data again to say, does this work in ADHD? Does this work for this condition? And it's kind of hit or miss. You'll see some parents who say like, oh, this helped me so much, and others who will say no. And then the other one, they'll say, oh, this didn't work at all. So it's kind of a trial and error when it comes to you seeing several drugs that do the same thing. Once you get out of first line, you're just like, let's see what happens.
So for choosing your ADHD medication, obviously it's patient specific because it's not one size fits all. So obviously you want to talk to the parents and the patient in regards to what their preference is, especially when it comes to scheduling their dosing. Some are extended release or sustained release, which could help with avoiding with school doses. And then if they have a better time management, I guess, or they have the ability to take more than one pill a day, then they could also result to that. But also another thing that you want to take a look at is the side effects that are tolerable. And again, this is going back to what the side effects are. If the parent wants to deal with the side effects and they prefer the outcome, or if the patient is okay and tolerating the side effects, Another thing would be the needed time for coverage, like I said. Some sustained release and extended releases are good for like 8 to 12 hours or more for symptom control. And again, like I guess like the parents and the patients, this would be a conversation with them to see like when it would be best or what type of medication would be best for them, especially if the outcome is to help them focus in school and homework and all those things. Also, obviously, what plays an important role is the ability to swallow pills. If not, then you would probably have to find a different route. If there's a different medication that allows for that. Coexisting tic disorders, so and emotional or behavioral conditions. So a lot of the stimulants can worsen tics. So you might, if they do have a coexisting tic disorder, you maybe want to do a non-stimulant medication first. It's preferred to reduce the possibility of worsening those tic symptoms. History of substance abuse in patients or household members. Since most of these medications that we talked about are class 2 drugs, we could possibly talk about alternatives or also finding a way to deter somebody from being tempted to abuse these drugs. Talking about cost, so a lot of the extended release and brand names are expensive, and obviously like this, I don't know, I guess like in the military realm we're a little bit more sheltered, but this is mostly going into the civilian side. Just think about that if for those patients who obviously have want to have a manageable scheduled dosing and they want to choose an extended release, be open to them, letting them know that it's probably going to be a little bit more expensive than the instant release or also the generic. So just keep that in mind. And then prior to initiating your treatment, as you guys have gone through these slides, you've noticed that a lot of them caused like cardiovascular or metabolic issues. So some cause, especially your stimulants, will increase your heart rate, possibly hypertension or hypotension, and a lot of weight loss also. And especially because we're putting children and teenagers into these types of medications, we obviously don't want them to be losing any weight because, you know, we want them to be growing and obviously the growth plates and everything like that. So that's something to keep in mind. So you want to be making sure that every time that you're seeing them, you're following up, you're conducting a baseline and obviously getting their vitals as well as their height and weight and all that stuff. Next slide. So just to shorten this, it seems like stimulants are better effective for ADHD. It seems like it has a better effect. Amphetamines versus methylphenidate. It seems like amphetamines are preferred for decreasing ADHD symptoms. Long-acting versus short-acting. It seems like long-acting has less abuse potential. And then in about 50% of cases, if one patient is not responding to a stimulant, possibly switching to another might help also.
So you see several things, right, that you have to look at whenever you're prescribing. Again, one of those things that give you the drugs, they're on paper, black and white, and then it becomes the art of you trying to pair and figure out what dose works. Also, don't think that this is just limited to kids, because adults take stimulants as well. So just kind of keep that in mind as things continue to progress and evolve when we're talking about us using these medications for ADHD. Y'all want to do your 10 minutes now? We have 3 minutes. Let's do 10 and come back. So 11 or 10 minutes. So.
A few months ago, anxiety and depression were ruining my life. I was struggling at work. Hey, I was struggling as a father. God, come on, Andrew, you can't be mad at school. That's worse than struggling as a husband.
My mom's doctor thinks that she's never entered in this facility. Like,
A couple of beers. A couple of beers is a revolutionary medicine that treats anxiety and depression fast. Admit it. I'm back to my old self. Andrew! I'm everybody the best in the whole world. My God. You guys laugh at how stupid you are. Take it. Even though my body's excuse me? Sorry, I'm just having a tough time adjusting to my new medication. So, it works simple. A couple of beers quickly turns a cloudy, rainy day into a sunny one. It's that easy. Now I'm the me I want to be. And I'm not the only one who's noticed the change.
Insurance makes me feel so bad for skipping her birthday trip, but it's like,
Hey. She just tells us to do something uniform. A couple of beers is a clinical treatment for conditions like boredom, depression, winter, museum, hangovers, affair, and moderate to severe Italian wife. If you miss a dose of a couple of beers, don't worry. You won't. Brother, you will never miss a dose. It's kind of the only thing you really remember after a while. Just to take it. The most common side effect of a couple of beers is drowsiness. So you may want to ask your doctor about a little bump. Once the drowsiness of a couple of beers sets in, you simply take a little bump, like a medication pills thing. So if you're ready to get your life back, talk to your doctor about a couple of beers. Maybe even a little bump.
can you come sit down? We need to talk.
No. What's the big deal? Calm down. God.
How I see it, it's gotta get to the next test, and then we have a gap until the radiology test. Right? Radiology and then Pharm. And after that, I'm like, you know, my handwriting is it's not like a treatment. Yeah, so like how it makes it easier is I like cut up potatoes and then I air fry it. Yeah, well, not even spray. I just like sprinkle a little bit of avocado oil, toss it. The spray is good, but like in this case, there's a giant one. Instead of spraying each individual one, I just do a light like drizzle over them, and I just toss it. I do a spray for like if I'm like air frying and then when I'm running. For that, and then like a quick chili on like that. I mean, for a quick chili, all you like it's like ground turkey, jalapenos, onion, garlic, and then I like salt, pepper, garlic, onion, some powder, some other tomato paste, and then some broth, and then like that goes down. And then but I really with like using cheese sauce is like either like African wedges or like low fat cheese, some low fat cheddar. and I use like oat milk just as a liquid because it's much more calories, and I'm like, all the other ones you over the stove and add like a liquid. So it's good. But all the flavors like something up like anywhere from 40 to 5 calories. Yeah, so then yeah, we had like at 9:30. That's when my wife like I started to get 9.
Alright, this next song is a special request from the back row, all of them.
I said it this way. I thought it was 300. I said it this way because I have the recording. So people that want to listen to the recording, but yeah, so it's basically for the IRL shit. You'll see two notes in there. So yeah, you like play the recording and then just like that would just help if like my handwriting is shit, just to line up what he said. If it's helpful.
Oh,
Alright, sit down.
for the chorus.
We got shit to do, sit down please. Alright, here we go.
Alright, we hop over to that next slide. So first drugs we're gonna be talking about are modafinil and armodafinil. Biggest things I want y'all to think about with these is how similar they are and what they do to meth and amphetamines. So Derek already hit on it, as far as amphetamines and their use in combat, and those drugs were all developed in between World War I and II for combat. Now you can see here, our clinical use is for excessive sleepiness. So if soldiers are excessively sleepy, or they have something associated like narcolepsy, that's gonna be our indication for using this. Now, if you're thinking amphetamine seems like a little bit much, Brian, why would I want my soldiers to be on amphetamines? What can amphetamines do for me? I've got a story as well. Going back to World War II up in Finland, there was a Finnish soldier, isolated and alone. No shit, there he was, all by himself, feeling excessively sleepy. Fortunately for him, he had his platoon's entire supply of amphetamines on him. Now, he went with the mindset which can get you, which is that if a little bit's good, a lot is even better. So he took all of it. He immediately went into a delirious state and blew himself up on a landmine. But that was not the end. He woke back up sometime later, and then for over a week, skied just under 250 miles back to his own forces, and he made it back, thanks to amphetamines. He was about 90 pounds when he got back, so there are some side effects associated with that. But getting back on track here, Provigil is the biggest one I wanted y'all to be aware of, because you guys may see in high-intensity operations, Provigil being given out to soldiers to keep them up for the duration of operations. So obviously, it will improve our wakefulness in adults. We saw that sleep apnea, that narcolepsy, or that shift work disorder. Adverse effects are exactly what you'd expect from a large stimulant. We're getting that headache, nausea, nervousness, and anxiety, as well as a decreased appetite. Surprise, surprise. We can also get chest pain, hypertension, and other cardiac events. And do know that we have potential CYP interactions with the listed substrates down there at the bottom. And effectiveness of contraceptives may be reduced because of that. Moving on to you, Aaron. What you got?
All right, these next couple of drugs, they're stuff we've all done before. So we'll start off with caffeine. All right, the best way to learn this is to read it a few times and remember it. Mechanism of action, it's going to antagonize adenosine. Oh man. It's going to bump some stuff up. Let's see. I mean, yeah, biggest thing here, everything kind of just increases. Next slide.
All right, y'all, we have to take an exam, right? And we have to dump everybody. So if you don't have a control, that is fine. But we still need to have the information to relate. Okay? So with your mechanism, what do we want to say about our mechanism? What is it?
So it is, it's increasing your cyclic AMP, and it's going to do that by inhibiting the phosphodiesterases. It's also going to increase your ventricular response to CO2. So some of the side effects that patients will get from caffeine, whether it's prescribed or used on their own, they will notice a decrease in fatigue, increase in mental alertness. You're also going to have other systems that are affected, so heart rate as well as contractility, and that can depend on the method in which the caffeine is ingested and the amount that they drink and or take, excuse me. And a lot of caffeine drinks, they'll have other ingredients as well that could work synergistically with that. It's going to improve respiratory drive, enforce in neonates, so it's something that you may hear or see about being given to young babies. And as we are all pretty familiar with, there's a mild diuretic action, so that will increase their desire and need to urinate. All right. So clinically,
Migraines, I think typically this, a lot of times given in an IV form, especially for, what's the word? Epidural migraines, right, after you have a baby?
So most of the time when I have seen this, or what I tell patients, which is what you can tell patients, I tell them to drink a soda with caffeine after they take any like of my orals that we give them for migraine. That's whenever I tell them to use caffeine. Also, if you think about Excedrin, Excedrin has caffeine in it. That's the one that's over the counter with like Tylenol and all this other stuff in it. But like the caffeine is supposed to try to help vasoconstrict when we're talking about like migraines. So when we talk about it next semester, that's the only thing that I talk about it in is like you're giving it with an oral that they already have. I haven't seen it used in that capacity. So for us, for the exam, just remember it as like I am gonna tell somebody to take their migraine medication or take an ibuprofen and tell them, hey, drink caffeine. Some people can just have caffeine and their migraines will go away. So just a tip for you to give to your patient.
So non-clinical uses, and this is kind of going back to, like we talked about, like for Tylenol PM and stuff like that. Caffeine's in a lot of things and it can be used in varying amounts. Sometimes your patients might not know how much caffeine they're consuming, or if it is in something else. So just have a conversation about their normal caffeine intake if you are considering prescribing something with caffeine or giving something with caffeine to not overdo it. So again, sleep deprivation, mental acuity, physical performance as well. Let's see, so adverse effects, common, mild. A lot of this can depend on if they've eaten, what they've consumed with this, or just any other confounding factors that the patient presents with. So anxiety, confusion, possible suppressed appetite. It can make them more irritable. So sleepiness, I guess it's kind of more like a rebound thing, right? You're just going up and going back. Sleep. Oh, sleep.
Yeah.
That's
And
a big
that,
one.
just think about like insomnia. I don't sleeplessness.
So sleeplessness, dizziness, blurred vision, dry mouth, flushed skin, and upset stomach with some other GI issues. And if it's done at higher doses, a lot of times too, like in conjunction, going back up to that physical performance, if you do something that's going to increase your heart rate and then drink something that's going to increase your heart rate, you can have those negative side effects there. So tachycardia, chest pain, agitation, and delirium.
And then think about this, it's like somebody who doesn't have caffeine often, they're gonna be more sensitive to it, right? So a little bit may make them feel like these more serious adverse effects. So in pharmacy school, everybody was drinking coffee and everybody was on some type of stimulant. I was like, well, I'm not gonna do a stimulant, I'm gonna try to drink a Red Bull. The worst thing I've ever done in my life. I slept in the bathroom that night because it was so bad. Also, I tried coffee before and the same thing happened. So like if somebody is very sensitive to caffeine, you can see where they have the tachycardia, the chest pain, all of that can be just from a little bit of caffeine. Versus that person who may drink coffee every single day, who may drink a Red Bull every single day, or any drink every single day. Take that into consideration whenever you're talking about the dosing of caffeine also. Even if they're taking it in conjunction with their migraine meds, make sure that you're taking it into consideration on what they are typically used to.
Oh, and just to keep on the slide, at the very beginning, these are stimulants not for ADHD. So we have MDMA. It's a class 1, but there are a lot of efforts being made to introduce this into treatment plans. However, that hasn't happened yet. These do have street names, ecstasy or Molly. If you're in an instance where you hear about this, just because a patient thinks that they took one of these two things, it could have been mixed with something else. So keep that in mind. But in active form, this is what it is. It's a hallucinogenic as well as an amphetamine. So you have a combination of effects here. that are gonna kind of enhance each other. So big difference here is that hallucinogenic effect. Adverse effects, so acute symptoms from limited short-time use, initial use, you'll have muscle tension, bruxism, increased body temperature, heart rate, blood pressure, as well as an acne-like rash. And then chronic, from repeated use, you're gonna have issues with neurotoxicity, rhabdomyolysis from a lot of those muscle issues, cardiovascular and renal failure. Again, this is being, it's shown efficacy to treat PTSD, but it has not yet been approved for use. All right, and check on learning. You have an 18-year-old patient with ADHD, presents to the clinic complaining of difficulty falling asleep at night. When asked about his drug regimen, he says he takes Adderall once in the morning and once after school. And so it's asking us what our best recommendation would be. Just skipping down here, you don't want to fight fire with fire, so A is not the best option. Swapping drugs right away, not a great idea. So if you kind of look at the timing that he's taking this Adderall, taking it after school, depending on what time he gets out of school, and with the half-life of Adderall, that could be impacting his sleep. So D, adjusting the timing of his Adderall is the best answer here.
So you will see this a lot. It will come to you, you may not have been the person who prescribed it, but you may have to be the person who fixes it. So patients, you will see where some are on extended release and immediate release, kind of like how we were talking about like some of our sleep meds as well with our Ambien. But you'll see this a lot with these, where they may be on an extended release and then we put them on an immediate release. You'll see where some people take it 3 times a day. So every patient is different. Your job is to try to figure out that timing and like what works for your patient, okay? Because if you see where they are having insomnia and stuff like this, you're trying to push back that dose. You may have to, if you push back the dose and they're still saying they experience that, then you may have to put on something else that is not a stimulant to try to calm them down before it's time for them to go to bed, okay? Also a potential of moving a bedtime, depending on how old that person is, okay? So several ways, but the easiest thing for you to initially try to do is shift that time.
Great. So when considering pharmacotherapy for weight loss, it's kind of a multifaceted approach. There isn't just one thing to consider. So starting off here, we're looking at our list of meds that are associated with weight gain. And ma'am, do you want us to know just the classes specifically?
Just the classes, not the amount of weight and all of that. Like, what are your drug classes that you have? And then when you're looking at your antidepressants, just know what things are potential antidepressants, right? So my MAOI, my SSRI, because I could give you like an NRI, which is associated with as much weight gain. So paying attention to the subclass of your antidepressants is important. Your antipsychotics, we've kind of done this already, so as long as you know that it's an antipsychotic, I won't test you over that particular again. So for your antidepressants, yes, know the subclasses, not necessarily the drug. Okay, so know MAOI, know mirtazapine. We're gonna go over this when we go over antidepressants, so you're gonna see it in more detail, and you will need to know it for that part of it anyway. Okay, so it just seems like a lot here for the antidepressants, but we haven't talked about it. That's what we're gonna start tomorrow.
So next slide. So here's this FYI, this just goes into to a little bit more depth. And something that's important to consider with these other drugs that affect this. Most of these do treat things that are going to be important to your patient. So being aware of not just being able to stop something due to their desire to lose weight. So here with some treatment guidelines, there are, again, other things we can do. So reducing energy intake. So diet management might take a little bit of work, might take some referrals to a nutritionist or someone like that. Increasing physical activity, behavioral skill training. So you can't just treat, you can't teach an adult, you can't just tell an adult to do something and they'll do it. Sometimes they might have to do some refinement on some of those behaviors they've had for a while. So pharmacotherapy, we're looking at that being more indicated for patients that are a little bit heavier, that BMI in the 27 to 30 kilograms per meter squared range. And then surgery, you're looking at your a little bit more morbidly obese patients, especially those with comorbidities.
So just note the difference between if I have a comorbidity or not. Because if I have a comorbidity, then I'm more prone to complications. That's why you see that threshold drop as to when we'll initiate medication. Most of the time before you initiate treatment too, you're gonna try to tell them to start working out. Because you want that habit developed while they're taking the medication. And like you said, the referral to nutrition is also gonna be a big helper and a key role for you because you can make me work out, you can put me on weight loss meds. If I still want to eat McDonald's every day, I'm probably not gonna be in a great position, right? So like those are the key players. The medication is not gonna do everything by itself.
And this just reinforces that. So diet, exercise, lifestyle changes, super important to go with that. We're gonna need to work on new habits, new behaviors. There might be additional factors there as well. Pharmacotherapy is a good adjunct to these changes, but it won't be able to do all the work on its own in a safe way. And in general, if you're not seeing some results, for example, you're 5% after 3 months, you need to reconsider your treatment approach.
Don't remember all of the weight percentages, group 7. Don't remember all of the weight percentages. I want you to know what the drugs are and like how you're going to potentially augment therapy and that it's important that it's not just your meds, that you also need exercise and diet as well.
Alright, so pharmacotherapy for obesity. These are some of the classes with your reduced appetite. There on the left, your reduced fat absorption and combination strategies on your right. Notice that under the anti-diabetic, you have your GLP-1 agonist. That is your first line, and that's what we're going to be starting off with. So our liraglutide, we kind of came up with a little acronym that hit all the points we thought were important. So LiraSlim, L for low abuse potential, I for increased insulin production and satiety, R for reduced glucose and weight, A just stands for adverse effects, so you're just gonna have to go over those. Just like anything else, you have your nausea, vomiting, diarrhea, pancreatitis for your diabetes, S for the route of administration, so sub-Q daily, and you're titrating that. Did you want us to know the actual, alright, so just sub-Q. L was limit, one second.
While he's looking at that real quick, note up here at the top, and you're going to see this with some of our other weight loss meds and like medications that we use for diabetes. You'll see the generic name, but then you'll see you have 2 different brand names. Saxenda is what we use for weight loss, but when we're talking about our Victoza, that is what we will use for our patients who have diabetes. So these are 2 different brand names, but the same exact generic name, the same mechanism, essentially, but one is targeting specifically weight loss, and the other one is targeting your diabetic patients, okay? So same drug, marketing, 2 different brand names.
Alright, and that L was limit in thyroid cancer because it's one of our contraindications along with pregnancy and pancreatitis, considering that pancreatitis is also an adverse effect. I for interactions, essentially just delayed drug and nutrient absorption because of the delayed gastric emptying. And then M is must stop or discontinue if 4% of total body weight is not lost after 12 weeks at max dose or 16 weeks after initiation of therapy.
So, big drug that you will see prescribed a lot, I will tell you with a lot of these that we're talking about now, which are also our diabetic meds, you're gonna have a lot of GI issues. So a large percentage of your patients are going to experience those GI issues. With pancreatitis, this is more so when you have your diabetic patients, you'll see that the dosing will vary depending on if you're using it for weight loss versus if you're using it to control their glucose level. So that's what that is. Like you'll see different people respond differently. And this hypoglycemia in your patients who have diabetes, this is again, some of your patients will have high glucose levels. They can take medications that can drop their glucose levels down, which is what is called hypoglycemia. So what this is saying is because this does lower glucose, you can see some of those patients experience hypoglycemia symptoms, which is like dizziness, confusion. If they're very hypoglycemic, they can end up in a coma. So there's different ways that patients can present. You're more so worried about just your patient who is a diabetic than if you were just prescribing this for someone who is obese, who wants to lose weight.
Okay, this is semaglutide, in the news a lot lately as Ozempic, the magic pill for, or the magic injection, I should say, for getting skinny. So same thing as the previous drug, 2 different brand names, same exact formulation as I understand it, but just marketed to do 2 different treatments. It's a long-acting GLP-1 agonist, and it keeps food in your stomach, and presumably because there's still food in your stomach, you're not gonna eat as much. Is sub-Q, we're not gonna worry about dosing.
That's really it for this one. So again, when you start these, you'll start them at a lower dose to see what their response will be, and then you are titrating up every 4 weeks. So these boxes right here, they all have different strengths. So you can continue to like titrate someone up. You can keep them where they are. If they're having a good response, you don't have to lose them. If you do titrate them up because they're wanting more weight loss, then you can say, all right, I want to increase your dose in 4 weeks. If you increase that dose and then they become very symptomatic or they're now complaining of more GI issues, and that means they can't tolerate that dose, you go back down to the one that you were on before, and then you can slowly try to titrate them up again. Some patients may not be able to go up at all and they're stuck at that dose. You leave them on that med for, typically we try to leave them on it for about 16 weeks or so to see that weight loss. And then again, your idea is that you're developing good habits so that they're not just relying on this medication. Because you don't want them to stay on the medication for forever. It's not what it is. It's trying to just help them get to a healthy weight and keep it off. Some of your patients are going to just rely on the med. No matter what you do, they're going to do what they want. They're going to eat what they want. They don't care. Okay? The medicine is going to do it for you. So just continue to talk to them and be patient with them and make sure that they're going to those nutrition appointments.
Okay, same kind of adverse effects as the last one, GI. Pancreatitis is rare, and this is a self-injection, so there's going to be some people that don't know how to inject themselves. Contraindications, pregnancy and thyroid cancer, the stuff in the brackets is just 2 types of thyroid cancer. And drug interactions, I mean, that one looks fairly obvious because of how the drug works. It's your stomach isn't going to empty as fast, so it's whatever else you take isn't going to take effect as fast. This one also has the same kind of thing, where if you stop, if you don't lose, if you lose less than 5% of your weight after 12 weeks. Kind of a thing that I made up. It's a little cheesy to remember it if you haven't seen the multitude of commercials. Is so S for small or slim, and blue like your gluteus maximus, it makes it smaller. Makes your butt smaller. That's all I got.
And then the other thing too, this thyroid cancer, it is a have seen it in mice and not so much in humans. So making sure that you're having that patient history is important because even if they have a family history of it, you're more cautious about it. So you're like, all right, let me make sure that they're not experiencing any hoarseness, they're not having any throat pain. Like that is what you are checking whenever they come back in. Even if you didn't start the medication, if you see them on these, those are like the basic questions that you can ask to say, hey, is this something that I need to be worried about? Because it doesn't directly have to be that patient with the thyroid cancer, it could be a family history of the thyroid cancer too. Yes.
So they have their thyroid removed and you're just not taking meds to T3T4 all the time, can you still take it?
Wait, say it again?
So if they got the thyroid removed and they're taking off T3T4 all the time to maintain, can they take it removed?
They could take them. It shouldn't do anything. It shouldn't. Well, let me not say Ozempic. Let's use the right Wegovy, because the Ozempic is the one for the diabetic patients, and Wegovy is the one for your weight loss. So try to remember your W with your W for weight loss. But yeah, it shouldn't do anything to that person, especially if they don't have a thyroid. Now there's no thyroid there that I'm worried about making cancer worse or potentially increasing the risk of cancer. It's fine. Yeah, double check everything. But the way I would do that is if they don't have the thyroid, then I'm not worried about it.
Didn't know if like this is big.
I'll check. I'll check.
Okay, this is tirzepatide, similar like self-injection, just as the last couple drugs, and similar kind of thing, same drug marketed to two different targets. This one acts on two different receptors, GLP-1 and GIP. GIP increases insulin sensitivity and secretion and suppresses glucagon, so you as it's just a slider. Yep. This one can be used for, or is used for diabetes, or diabetes type 2 to increase their sensitivity to insulin, hopefully get their blood sugar down. I think, ma'am, it was one of your suggestions to bring a family member with the patient into the, when you're telling the patient about this, so then the family can kind of peer pressure them to do like diet and exercise changes.
Not peer pressure, but I mean, I guess. So again, like having that accountability partner, right? Like having somebody to help you along the way. The big thing about this one too, same exact things like we were talking about before, your biggest complaint that you're gonna see is gonna be that GI disturbance. So like stomach pain, a lot of diarrhea. Some people will say like they feel nauseous all the time. Like that is the biggest complaint that you hear here. And then again, injection site reactions are just because I pierce my skin with something. Anytime I pierce my skin with something, I can have redness there. I can have a minor swelling. If they tell you that like it's red and it's hot and it's been there for a long time, that's more where we're worried about an infection and not just like an injection site reaction. Okay, like those typically go away after 24 to 48 hours. Where I like if I inject myself. If I have an infection, it's going to be there for a longer period of time. Okay, more painful.
Let's see here. Up next is orlistat. So when you see orlistat, you're going to think of fat. Orlistat or the fat. So orlistat is a weight loss pill that works by blocking about 30% of fat you eat from being absorbed. This blocked fat will pass out of your body in your stool. And this can cause gassy, oily, or urgent bowel movements. And the key thing to know is eating less fat will lead to fewer side effects. And lastly, an important consideration, orlistat or the fat will inhibit the absorption of fat-soluble vitamins. So remember, when you see orlistat on the test, orlistat, 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 fat, orlistat is fat.
Other things, sorry, that I want y'all to remember with your interaction is part of the mechanism, which we'll learn next semester, of your warfarin, you will see where now I have more of that drug that can cause me to bleed easier. So they will have more bruises on them. If they cut, like if they're shaving themselves and they cut themselves, they will bleed for a longer period of time. So this is one of those more serious ones that I'm worried about. And then on the levels, if we kept talking about thyroid, if you have somebody who has hypothyroidism, we will sometimes have them on levothyroxine. And so this medication is trying to level out their thyroid hormone. What happens if I start taking this for a while weight loss is that I can see where now my levels will start to get out of whack. You'll start to see your patient become have more symptoms. So if you are prescribing something like this, or if you're thinking about prescribing levothyroxine to one of your patients, just make sure that you understand if they're taking orlistat that it can have that interaction. So warfarin and your levothyroxine along with your fat soluble vitamins are the ones that I'm more worried about, you know.
Okay, I'm going to be talking about phentermine. The way I like to think about it is, for phentermine, is the phentermine fires up the fight or flight response. So I want to just think of a fast fire. So you want to lose weight fast. Phentermine is the drug for you. So how it does that is it's like a pathomimetic, so it mimics the fight or flight response by releasing norepinephrine. So since you're going to fire up the fight or flight response, it's going to cause those reactions, so like dry mouth, constipation. But why you want to think of a fire is because you don't want to give it in hot weathers areas. So like taking a PT test in San Antonio, probably should not give it to that patient, just because you have that increased body temperature. Also, so contraindications, don't give it to pregnant patients and lactation. Obviously hyperthyroidism, because they're going to be, high temperature, high blood pressure, like tachycardic, so do not give it to those patients. Glaucoma, hypertension, history of drug addiction. And obviously, since it's a sympathomimetic, don't take it at night. And since you're taking it, don't just stop taking it out of nowhere. Make sure that you don't take it late, don't suddenly stop. If you have tolerance, that's when you slowly titrate and stop the drug. Your patient might be inclined to start taking more of the drug to overcome the tolerance, but that is not recommended.
So this drug used to be very, very, very popular. Not so much anymore. People still do use it. You will still see it prescribed. Will say it is a control medication because it does have that abuse potential. It is an effective medication. Most of the patients who complain about this med, they have those activating symptoms, right? So those cardiovascular symptoms are usually what people complain about the most because they actually feel the tachycardia and the palpitations that they're having. Other things to just know, make sure you're doing a washout period of 14 days if you have an MDLI that you want to put your patients on. So we're going to talk a little bit about those. Make sure you 14 days in between.
Good to go. All right. I think it's like 11 slides, and then we're at lunch. So, good news about the next 4 slides is we've seen every single drug already. Now we're just putting it together. So the first one, Qsemia. So you think you see me now? You see me now. Or if you want to get rid of your fat top, take phentermine and topiramate. So same thing for phentermine, right? It's the norepinephrine, it increases it, so that sympathomimetic activity, it's like an upper, right? You're increasing that SNS. So when we're looking later at like adverse effects, right? All the same exact stuff as the last one, the phentermine, because of the phentermine in this one, and that's what gives it the class 4 controlled substance. Topiramate we saw earlier as well, but instead of now, it's looking at curbing the craving. I think before it was alcohol. But now it's more catered toward, with that combination of phentermine, we're looking at curbing that craving and the appetite suppression. For dosing, we're looking at kind of that same buildup of dosing over time. This is, to me, it looks like it's a longer term drug. You're not gonna just like stop and start this one. You're kind of like see your patient and how they're reacting to it. And you have to taper off if they're not responding well. You can't just stop it. Go ahead, next slide.
So big thing here. Longer term, I guess, kind of. So most of the patients should be on it for will see that some of them will go to a different doctor to get it prescribed by someone else who doesn't have the med chart. Because they will respond to the med, but if they haven't gotten the weight loss that they want, they will go and drug seek for it. Also, you will see that sometimes you will put someone on this, they stop taking it, the weight comes back, and then you'll prescribe it again, and then like, it's like the yo-yo effect. So again, the habits are what are important. And then watching out for this dose cutoff. If somebody has a creatinine clearance that's less than 50, this is higher than what we typically see. Typically, we start to worry about our creatinine most of the time when we're talking about less than 30. This one is less than 50. We will stop increasing their dose at that 7.5. I just want you to remember the creatinine clearance at less than 50, which is different than what we typically see, which is always usually less than 30.
All right, so all pretty much the exact same adverse effects. There's a couple of weird ones in there to draw your attention. You get that metallic taste that we saw earlier in the slideshow. And then that's kind of paired with the dysgeusia, which is like you altering the taste of your food, maybe in your benefit, I guess. I mean, to me, if I was trying to lose weight, I probably want my food to taste weird. I probably wouldn't lose much. I don't know. CNS impaired, so you're kind of like that impaired cognition, which is why we'll see anybody that's like an alcoholic or drinks a lot. Alcohol is kind of like a don't do on this drug. If you're just in more impairment on that cognition, bad side effect. And then same thing with that decreased heat tolerance, which is an important one. Big contraindication is the pregnancy and lactation. It's the reason why the drug is on the REAMS program. So you need to be counseled. And I think there's even something I read that you have to get a pregnancy test before being prescribed this drug because it has so much teratogenicity associated with it early in reproduction. So you might not be fat, you might be pregnant. So congratulations, you're just bringing in life. You don't have to lose weight, it's natural. All right. And then you don't want to have an MAO inhibitor because if you're increasing norepinephrine from the drug and you have something that's not degrading norepinephrine, it's like 2 uppers. That's bad. All right, next slide. Last one for phentermine and topiramate. So the same thing, the drug interactions, right, the MOA inhibitors, leading to that kind of too much, right, and that serotonin syndrome. And then alcohol worsening the side effects, because you're getting that more of that mental depression. And then for oral contraceptives, I know that was a big one last block, is where we always talked about what happened to oral contraceptives. And this one, it lowers the efficacy of your oral contraceptive. That was a weird one for a ketogenic diet. I don't know the cause and effect relationship between being on keto and the drug interaction, but yep. And then, as mentioned, the REAMS program there below. And topiramate, make sure you're taking fluid, because topiramate can, that's kidney stones is an issue, so you want to make sure your fluid intake is high. Anything else there?
You already make sure you're noticing that REM, like pointed out, which is a big deal. Also, with all of these weight loss, like if somebody is pregnant, they shouldn't be worrying about losing weight. So that's kind of how I remember that they shouldn't be taking any of these. When you talk about the ketogenic diet, I heard you say that. You're just worried about the things in parentheses happening. It can increase the potential of those things happening. So that is why you don't want someone on keto while they're doing it. Okay? And the other diet are fine. This you're worried about it because it can just increase the risk of them having kidney stones, the metabolic acidosis, and there's a whole cascade of things that happens after that.
All right. Now we got naltrexone and bupropion, both which we've seen before, but now you're just putting them together. I kind of used the brand name Contrave to remember this one. Sounds like I can't rave, so you can't go to the rave if you're too fat and start to dance. So you're taking it so you can get back on the dance floor later. Cool. All right. So when we're looking at mechanism of action, blocks opioid receptors, which is the naltrexone. So you're modulating that reward center, so you're reducing the cravings, and then bupropion, it's one of those antidepressants, so you also can see it, which I thought was kind of a unique thing in smoking cessation. I'm assuming it's just because you're keeping the feel goods going.
Talk about it a lot more. We see this a lot with smoking cessation, especially our patients who are depressed and they want to stop smoking. This is a very good medication. We'll talk about it.
Hint on the check on learning in a couple of slides. consistency. Alright, and then just notice for dosing that it has the dose adjustment and the read-on hepatic impairment. Previous one was just the hepatic that child fused for, but this one adds the renal element into it. And then next slide, we're looking at the adverse effects of it. Big one here to highlight at the bottom of those is the suicidal ideation and the suicidality. Kind of ironic considering bupropion was the antidepressant one that you prescribed, so kind of a standout one. And then a big one for increased heart rate and blood pressure, right? So obviously if the person has a high blood pressure or has hypertension, probably don't prescribe something like naltrexone or bupropion. And then also contraindicated there is somebody that's anorexic or bulimic, and obviously because you don't want them to have less food intake. And then the MOA inhibitor is the same as last. Anything else there to mention?
No, you're gonna learn about this tomorrow. A lot of your antidepressants carry this black box warning. So this is a black box warning that you see in because of that bupropion portion of the medication, okay? Same thing with our opioids, just watch out because this has that naltrexone portion in there, okay? So it's not.
All right, last slide for naltrexone and bupropion. If you don't like the can't rave, you can do NABU, keeps you new and balanced, whatever you like. So the drug interactions is the high fat meals, because for some reason it can increase your seizure risk. Don't really know the association there, but yeah, high fat meals, and then obviously not using with opioids, right? So if you're blocking, if it's an opioid antagonist and you're using with opioids, you're just setting yourself up. You're precipitating a withdrawal symptom basically. You're having them on like an opioid pain reducer, or if they're actually just a drug user. So, and then the other down there, obviously we talked about the black box warning, suicide thoughts in the bottom, and then you as the provider managing and monitoring that patient's blood pressure and heart rate throughout the initial steps, and then obviously watching out for any sorts of change in mood and depression.
Big with this, so the question about the high fat meals, it interferes with the absorption of the medication, and so if you have a higher dose of the medication, it can lower your seizure threshold, which is what increases your seizure risk. So that's also why you see down here any other drugs that are lowering your seizure threshold will also increase the risk of having a seizure. So that's because of the absorption of your medication being increased with a fat meal.
All right, so just remember, fat top, get rid of your fat top. All right, can't rave until you lose some weight. All right, good. So other agents, symptomimetics. For this one, I just thought slimming, not safe for long term. That was one of the things on it. It's more of a short-term treatment for obesity up to 12 weeks. Same MOA as previously, increases the norepinephrine. Adverse effects is what you would expect with something that's stimulates the SNS, is increases the heart rate and the blood pressure. And obviously, if you're looking at insomnia, thinking about when you're taking the drug, probably not at 8 p.m. before you go to sleep. And then we kind of mentioned earlier in the slide as well, the SSRIs with fluoxetine and sertraline or other serotonin reuptake inhibitors, kind of increasing that good feeling, maybe also having some appetite suppression that kind of comes along with that. That's all I really had for that one. The table, so the drugs that we just spoke about, and for this portion, for my piece, was the two above the red box. So you can kind of see that the mean change in body weight's not the greatest, right? The bigger ones is what group 7 behind me just talked about, where we're seeing a much larger drop in percentage in that third column, mean change in body weight. So probably if you're looking to drop a lot, don't do the contrave.
So this is just important for you guys to notice because these are all of my substitute options that I have, right? Where my patient was having patients. So yes, I'm getting great results. These are the two that you're going to hear a lot about these days, like your Wegovy and your Zepbound. But when you look at your Kinsema, this one is a very good oral option if I don't want to inject myself, or if I'm like, hey, I'm adverse to needles, adverse to injection. So this is the best oral option that you have, and any of these are good, but these two are the ones that you are going to see a lot about in commercials and a lot of prescribing being done for these. So those are
All right, check on learning. Diabetes. Anybody recognize one of those on the right side?
What number?
Number 2, that's good job. That was group 8. All right, one for group 8. CV disease, cardiovascular disease. What we got?
4.
Oh man, I don't know what group 8's really showing out. Anybody back there? No, everybody's just like, let me go to lunch. All right, smoker. So we got 1 in 4 left, or no, yeah, we got 1 in 3 left. Smoker. I'll give you a hint. Nice. Number 1, naltrexone and bupropion, and last but not least, obesity with comorbid conditions was the fat top, or just benjamin, which I guess doesn't get prescribed a lot by itself anymore, as you said. Not as much. Okay. FYI slide. One thing I'll mention, I guess, is that the prior authorization versus the medical necessity all require that prior authorization, but if you want to help the patient reduce costs, remember that's the medical necessity piece as the provider. All right, and then finally, last but not least, when we're talking weight loss medications, a lot of times there is comorbidities that are associated with it. As we're learning in pathology, you usually just don't have isolated hypertension. There's a lot of other things. So don't just blindly prescribe something that's going to make them lose weight without thinking about what else it could cause. And then additionally, there's a lot more things than just overeating that cause weight gain. So when you're looking at like a multidisciplinary approach, trying to figure out what's actually causing them to hold on and retain and gain so much weight so fast or throughout their life. A lot of other things go into play. That's all I got.
Great job. Really quick, I wanted to reword something because I think the wording on the slide was a little confusing. Oh, so first this. I wanted you guys to just toss this out because I feel like this is going to make things a little bit confusing for everyone. So let me see what slide number. Slide 43. Cross these out from here. I don't want you to worry about it, just benzos is good enough. And then there is the table somewhere that people were confused about. Okay. We fixed it. Here. So the clonazepam before, remember it said not used or something for anxiety, put off-label. Because remember when I was talking to you guys about it and I was like, we use it, and we use it off-label. This is more so looking at when you look at the slide, it was saying like, oh, it's approved for panic disorder, like FDA approved for that, but we do use it when we're talking about anxiety. It's just not FDA approved for anxiety. So that's what it meant, not that we don't use it in anxiety. So I wanted to change the wording so that when y'all are studying, you don't get confused because of how it's written on there. So change it to like off-label for anxiety. You will see this prescribed for anxiety. You will probably prescribe it for anxiety. It's just not FDA approved for it. Okay? I think that was good. Yeah. Okay, so tomorrow, antidepressants will be our lecture, and y'all will finish that one tomorrow. So I'm hoping that we'll finish it tomorrow. If we don't, then we have another class. If not, then I'll get with your class leaders about canceling that class for Monday. Thank you.
Confusing what she was saying for the slide. What I remember was